Hello, everybody. So, welcome back from the break. We had two great sessions this morning. I'm Sally McAdoo. I'm actually the medical director for the Kidney Cancer Association. I've popped in a couple times and forgot to introduce myself. But yeah, now that I'm caffeinated and ready to go, we have a great third session. This session is going to be on the genetics of kidney cancer. I am happy to sort of introduce our speaker, who's going to focus in on a couple of the different areas surrounding this topic. He is a genetic counselor like myself that comes out of Cedars-Sinai. And his name is John Lee. And so Michelle Piccolo was a patient who was going to be joining us today. Unfortunately, she was affected by the hurricane in Louisiana, so she is not going to be able to join us. So if you are out there in the listening audience and you have had a inherited form or a genetic test that links you to renal cell carcinoma, feel free to send some comments and questions through that you sort of want to share part of your story and or ask some particular questions. But at this point, I would love to turn it over to John Lee, who can start the conversation.
Hi, everyone. Thank you, Sally, for the nice introduction. And again, I appreciate Radha, Sally, and the Kidney Cancer Association for having me speak today. I wanted to take some time to talk with everyone about the current state of genetics of kidney cancer and also touch upon what's important for patients to know. Just to start, I do not have any relevant disclosures. And the objectives from today's talk, again, are reviewing what patients should know about genetic counseling, as well as genetic testing specifically in relation to kidney cancer. I'm also going to discuss the current state of genetics of kidney cancer, and then also review some future directions that we're hoping the field will go into. It will be kind of broken up into a few sections, and I will take some questions during the middle if there are any, to make it a bit informal and certainly address any questions that anyone in the audience may have. So to start off, I just wanted to do kind of a quick review of cancer genetics overall for those of you that aren't familiar with it. So kind of starting from the very basics, ultimately, what is cancer? So from a very rudimentary standpoint, cancer very simply is an overgrowth of cells. Most of our cells within our body, it's very normal for them to grow and divide. And most of the time when cells get old or abnormal, they usually have a process in which they die off. However, cancer can occur when this natural process is interrupted, and these cells therefore then keep growing and dividing, which leads to uncontrolled growth, and therefore that can form tumors. Some tumors may be benign and others can be malignant, and obviously the malignant ones are the ones that are concerning here. Overall, we can group cancers into a few different categories. The two major ones are hereditary and sporadic, but there's also a third called familial. So hereditary cancers are ones that we believe a predisposition to these can be passed on from generation to generation. So you can typically see kind of a vertical transmission within a family, for example, a grandparent that's affected, a parent, and then maybe a child as well. Most cancers, though, are thought to be sporadic. Sporadic cancers are ones that do not have any sort of hereditary component. We think that these may be caused by some sort of environmental exposure, some sort of age-related change, or maybe some sort of, again, unyet or unknown cause at this point in time. But we typically do not think that sporadic cancers are passed on from generation to generation. And then the third category, familial cancers, we think are essentially a combination of the two. It's what we call multifactorial, or basically multiple factors. There may be an unidentifiable hereditary component that's mixed in with some sort of environmental exposure as well. Typically, how we break these down, for most cancers, we think approximately 5 to 10% overall can be hereditary, and about 20% can be familial, where you'll see, again, a clustering of these similar cancers within a family. And then the rest, which is roughly about 70%, are sporadic. So again, the majority of cancers are thought to be sporadic, which I know comes to a surprise to some patients. So a lot of them may think that more of them are hereditary than what we currently know of. But within our field, we do think even 5 to 10% is a significant number, and we're trying to identify those for various reasons. Also integral to today's discussion is an explanation of genes and how these impact us and how this plays a role within our development within cancer and without cancer. So starting off, everyone has 2 copies of every single gene. You get 1 copy from your mother and you get 1 copy from your father. Most of these genes, in particular ones that are related to kidney cancer, they're actually typically protective. Most of these, the function of them are what we call tumor suppressors. So they typically stop tumors from forming. So it's very normal to have these genes to begin with. It was actually be quite problematic if someone was missing a gene. But I raise this because from a colloquial standpoint, a lot of people, whether it's patients or providers, will ask if someone has a particular gene or not. Again, very technically, everyone actually has these genes, and it's really a matter of whether you have a normal version, which is actually serving to protect you from developing certain types of cancers, or whether you have a version that has a change in it, which what we typically call a pathogenic variant or a mutation. If an individual has a mutation in their gene, that can be problematic because it means that that gene is not functioning correctly and it's not able to offer that same protection that it's supposed to. An analogy that I like to use with my patients is thinking about a recipe for baking a cake. A recipe is the instructions or the gene in this scenario, and then the cake is the end product or what we call a protein. So a gene is used to create a protein, similar to how a recipe is used to bake a cake. If you have a normal cake and a normal recipe and it tells you to put in a couple of cups of sugar, your cake will probably come out fine. It'll taste very good. But if you have a different recipe that is a typo or a change in it and tells you to put in a couple of cups of salt instead of sugar, typically that cake would not come out correctly, unfortunately. And the same is really true for our genes and the proteins that they create. If you have a normal gene, then the protein that it creates is normally okay, and that should help protect you from developing certain types of cancers. But if the gene has that typo in it, again, what we call a mutation, then the protein may not form correctly, and therefore that person has some sort of increased risk of developing certain cancers, potentially kidney cancer. It's also important to note that a lot of these increased risks are not necessarily 100% chances. It can really range from just a small increased risk to a large risk. But for most of these syndromes, we do have a pretty good handle on what the percentages are. But again, most of them are not close to 100% necessarily. And we also think that there is what we call a two-hit hypothesis within these genes and cancers. So for most people that start off with two normal copies of each of these genes within their cells, they have protection from both of those genes. Over their lifetime, though, maybe in, say, roughly their 30s to their 40s, just as an example, they might acquire a change within one copy of the gene. Again, possibly an environmental exposure or something else that causes that one copy to stop working, but they are still okay at that point in time because they still have backup through that other working copy. Again, they were born with two normal copies and one has stopped working at that point, but the other version that's normal is still helping protect them. However, potentially later in life, maybe in their 60s or 70s, for example, they might acquire a second change within that same cell, and that second gene stops working as well. In that particular case, we typically think that's when potentially it can lead to a cancer after both of those two hits, as we call it. The big difference between sporadic cancers and hereditary cancers is that we believe that individuals that inherit these genetic mutations, they start off with one non-working copy of this particular gene within all of their cells. So for example, all of their kidney cells would start off with only one working copy. So at the beginning of their life, they're still okay and they're protected because they still have that one working copy. But for them throughout their lifetime, if they acquire just one change, because they're already also born with a change, at that point in time, they would have no more working copies in a particular cell, and that could lead to the development of cancer. So oftentimes, and we'll talk about some characteristics in a bit, but oftentimes we can sometimes see earlier ages of onset for these types of cancers, and that is really the main mechanism in which that may occur. Okay, so moving on to what is genetic counseling. So for anyone that hasn't had genetic counseling, just wanted to take some time to explain what we do within genetic counseling and essentially what to expect. So very broadly, genetic counseling is really the interpretation of personal and family medical histories to assess the chance of disease occurrence or recurrence. Also, our goals are to educate about inheritance, testing, management, prevention, resources, and research available to patients. And then our goals are really to promote informed choices to the risk or conditions. So it's also very important. A lot of genetic counselors take what we call a non-directive approach. We're not here to really tell a patient that they necessarily should or should not do testing. Our goals, again, are really to give patients all the information available and help them make those informed decisions ultimately. So what to expect from genetic counseling? The kind of very traditional model, which is, I will admit is changing recently, but the very traditional model is a 2-visit model. So During a first visit, this is what we typically call pre-test counseling. This is before a patient has had any sort of genetic testing. They would typically meet with a genetic counselor. They would discuss their relevant personal medical history. So for example, if the patient has had a kidney cancer or a different type of cancer, we would want to review those details, obtain pathology and other pertinent details that will help us make an assessment. We'll also take a detailed family tree in which we'll talk about typically first, second, and third degree relatives and ask about their health histories. In particular, have they had cancer? And if so, important details to know there would be what kind of cancer do they have, what age were they diagnosed, and any other pertinent things. Was it, on one side or two sides? What kind of treatment do they have? Any sort of information that patients can gather about their family history can be very helpful. We do recognize that everyone does not have 100% information about all of their family, and that's understandable and completely normal. As much information as you're able to gather will be helpful, though, for the genetic counselor. And then we typically will provide an assessment to let the patient know, okay, based upon your personal family history, this is what we're seeing. These are the patterns that are potentially concerning, or potentially, maybe the patient is the only one with cancer and they have a very large family and a lot of unaffected individuals that lived until later ages, and perhaps their type of cancer is not as concerning from a hereditary standpoint. So the genetic counselor, our goal is to make an assessment to let the patient know whether genetic testing is really something that would be advisable or not. If genetic testing is viable in the patient's particular situation, we would certainly go over all of the pros and cons of doing testing. There are certainly benefits and limitations to any genetic test, and we want to make sure that patients are aware of all of these limitations as well, so we set the expectations accordingly. And then we can also help facilitate genetic testing based on what the patient's insurance coverage may be, the best test for them in terms of number of genes to look at, the best laboratories that have good analysis of these genes, so on and so forth. And then we can help coordinate that process for the patient. During the second visit, this is typically what we call a post-test counseling visit. This would involve interpretation of the genetic test results. We would disclose the results to the patient, let them know what was found, and essentially what this means for them. So we would give management and screening recommendations accordingly to say, okay, based upon this result, this is what it means for you directly. This is what we think you should be doing. And then potentially for family members as well. A lot of this does have familial effects and can impact other family members, whether it's the patient's children, siblings, nieces, nephews, etc. And it's something that we can really help lay out for the patient in a very digestible manner. And oftentimes we can sometimes also have long-term follow-up. In our clinic here, and I know in a lot of other genetics clinics, we like to keep in touch with patients in particular that are positive and have genetic mutations. We like to keep in touch with them long-term, typically on an annual basis, because genetic information does change over time and we're constantly learning more. And what we tell a patient now based on their results may change in the future. And we always want to make sure that they have that latest information available to them. I do also want to point out that there are some other collaborative models as well within genetic testing. A lot of oncologists that we sometimes work with feel comfortable ordering testing on their own, which is totally fine as well. And we'll get involved for post-test counseling only. So sometimes, again, a physician will order the test for the patient, and then genetics or genetic counselors will be involved in terms of the interpretation and disclosure of those results. And I will also point out that there's a lot of changing service delivery models. One of the big areas of concern within genetic counseling is that, quite frankly, there are not that many genetic counselors compared to the need of genetic counseling. There are a lot of efforts within the field to increase the number of training programs and increase the number of genetic counselors that go into the profession, but really outside, not just within kidney cancer, but within many other types of cancers, the need for genetic testing is really exploding over the past few years. And it's, again, honestly outpacing the number of resources we have for genetic counseling. So in order to adapt to that, there are a lot of alternative service delivery models now, in particular telehealth, especially, I think this has really obviously come to the forefront over the past year or so due to COVID. But really, we're finding that a lot of telehealth models are very viable in terms of being able to provide genetic counseling services via telephone or video rather than requiring a patient to come into the clinic. And this, I think, is also really helpful for patients in terms of expanding accessibility. Not everyone lives near, a center that has a genetic counselor available. So this is really evening the playing field for a lot of patients in terms of being able to obtain the services that otherwise would have been a little bit more restrictive there. But a lot of clinics are still offering in-person visits as well. And personally, we're likely going to be offering a hybrid. model of both. But there are certainly, again, a lot of telehealth services that are currently available to patients. So I don't want that to be a barrier for patients that may not be aware of any genetic counseling services that are physically local to them. Okay, so what is genetic testing? So just to preface this, genetic testing historically has been used to define or refer to hereditary genetic testing. But in the modern times, it's important to distinguish that very technically there's various genetic tests that can be performed, and they can be broadly divided up between hereditary cancer testing, which is what we call germline testing, as well as testing of the tumor, which is typically what we refer to as somatic testing. The big difference between these is that germline testing or inherited testing, we're looking for mutations that, again, are passed on from generation to generation. These are present at birth and are really present within the individual throughout their entire life. Versus tumor testing and somatic testing, this is specifically looking at the tumor itself, and we're trying to analyze mutations that have occurred potentially over the patient's lifetime and are specific to the tumor itself and not necessarily present within the entire body. So focusing our discussion now on inherited genetic testing, typically how this is done is usually through blood or saliva. I know patients are often a little bit surprised to learn that this testing can be done through saliva. Historically, most tests that you probably have done through your physicians are done through blood work. That's still certainly available for genetic testing, but there are still very good and accurate options available through saliva these days as well. And again, what we're trying to do is essentially perform a spell check of these genes. We know what every gene is supposed to look like in their normal or reference copy. And when we do genetic testing, we're really trying to read through these genes to see if there's any typos or changes there. So we read through very carefully and compare them to the regular versions to determine if there's any changes there. This is typically most informative when it's performed on a family member when they have, or a person that has cancer. The reason for this is that we perform it on someone who does not have cancer. So say, for example, someone comes into clinic and they say, okay, I'm 45 and I've never had cancer, but my mother and my brother and maternal grandmother all had kidney cancer. It can be a little bit tricky to interpret those results for the patient who has not had cancer. For example, if we don't find any genetic changes, we're still left wondering, do their family members with cancer have a genetic mutation that was not passed on to this person that didn't have cancer? Or is there simply no genetic mutation in the family? So we typically will get a more direct answer when we test someone with cancer, if at all possible. Obviously, that's not always within the realm of possibility. Maybe those individuals with cancer are not local or not willing to do testing, and therefore sometimes we will accommodate that and do testing for patients without cancer. But again, whenever possible, it is really most beneficial for the family overall to test someone who has actually had cancer. Largely, the benefits of doing genetic testing would be it helps us improve risk assessment for patients. It can help stratify their screening. So for example, if we find that someone has an inherited mutation, we can then determine if they have any sort of increased risk of certain types of cancers. And we can use that information to develop an individualized screening plan for them. So for example, they may need to have different types of screenings or more frequent screenings than what the general population is doing. Sometimes it can help reduce uncertainty and anxiety. Sometimes patients will come in saying, okay, I have this very strong family history, and whether or not I have a genetic mutation or not, that can actually help me get a firmer handle on, okay, do I have a 10% risk of this or a 20% risk of this? And we can quantify it sometimes and help, again, formulate a plan so we have an action plan for them moving forward ultimately. And then this is also typically information that can benefit various family members. So it's oftentimes really not something that is, the information is not just isolated to the patient themselves. Indirectly, it will oftentimes have effect on multiple family members in terms of identifying possibly who else might have inherited predispositions as well. Typically, for most of these conditions that we're looking at, they are what we call autosomal dominant conditions, which means that all it takes is one inherited mutation rather than two mutations. But it just takes one mutation to actually have an increased risk. And typically the inheritance pattern for those would suggest that all first degree relatives of someone with a mutation have a 50% chance of having that mutation as well. So for example, again, children, siblings, parents would all be first degree relatives that would often be impacted by this genetic information. I will point out that there are certainly limitations to genetic testing as well. It's not all completely straightforward necessarily. One of the big ones is that we still don't know all of the genes that are involved within whether it's hereditary kidney cancer or other cancers as well. So even when we do genetic testing now, oftentimes patients will be offered a variety of sizes of genetic tests, which we call panels. But even with the largest panels, we're still discovering more on a almost year-to-year basis. So it's something over time. Even when genetic testing has been performed in the past, we may want to consider doing additional testing in the future to capture additional genes. There's also the possibility that it won't give a definitive yes or no answer. Very technically, when we do genetic testing, of note, there are 3 different results that someone can get. The first result is what we call positive, second is what we call negative, and the third one is what we call uncertain. So positive, very briefly, means that we have found a change in the gene that we know is essentially harmful. And again, that's what we call the mutation or the pathogenic variant, and that does confer increased risk of certain cancers. A negative result briefly means that we've read through that person's gene and it doesn't show any changes. It essentially looks like the normal version that most people in the general population have. And in that particular scenario, we don't, one of the limitations there for someone who's had cancer, we have not identified really the reason that they developed their cancer. And sometimes that can be frustrating to a patient who's had kidney cancer or other cancer. Sometimes they're looking for an explanation about why it happened. And if the testing comes back negative, we don't really have a direct answer for the patient in that scenario. And then the third result, this is really where a lot of the limitations come in as well, is the so-called uncertain results, or the technical term is VUS, or variant of uncertain significance, or variant of unknown significance. And what this means is that we've read through someone's genes and we have identified a change in the gene, but we do not have enough data at this point in time to really say, essentially, is this actually harmful or not? A lot of people do have normal variation within our genes. It's simply what makes us different from one another. Everyone does have changes that make us unique, but they're not necessarily changes that cause disease. So they could be things like hair color or eye color, but not actually cancer causing. But with the uncertain result at that point in time, we don't have enough data to really differentiate about whether this is a harmful change or simply normal variation. And really from a psychological perspective, we understand sometimes that can be a frustrating result for both patients and providers to receive, in that we don't have a direct answer for them. I will point out that the vast majority of uncertain results, typically over 90% of them in the future, will be reclassified to negative. So typically from a clinical perspective, most genetics providers will treat uncertain results as negative until proven otherwise. We don't typically jump the gun and tell patients to do things drastically different within their healthcare based off of an uncertain result, because the majority of them will get reclassified. And just very briefly, the way that they get reclassified, it's typically passive on the patient's end. So patients typically won't necessarily have to repeat the same exact testing every year to get a clearer answer. It's usually reliant on whether it's testing of other patients unrelated to that patient that have the same results, and then they can collate all the data, other research studies that come into play, and other sources of data. The laboratories, the genetic testing laboratories, are constantly trying to reclassify these results. I personally will get a reclassified result almost once a week from the various labs that we work with. And then we reach out to the patients to notify them at that point and say, hey, there's been some new information about your genetic test result, and this is what it now means. And we can give them a more definitive answer at that point in time. But it's important to understand that up front, we may not necessarily get a definitive yes or no answer. And then sometimes there can be psychological concerns as well, not necessarily only around uncertain results. Sometimes patients with positive results, sometimes there can be guilt around there in terms of the potential of passing it on to family members. Sometimes there can be associated depression about these results in terms of learning that there's increased risks of other cancers. And then similarly, sometimes it can cause anxiety as well. So it's important for patients, in my opinion, to have really informed consent before doing genetic testing, to really consider all of these options and the potential ramifications. I will stress that genetic testing is not necessarily the right choice for everyone. Again, it's really a very individualized decision, and I think every patient hopefully should be aware of all, again, the benefits and limitations of doing genetic testing, germline genetic testing, before they agree to doing it ultimately. And then also wanted to touch upon some of the challenges inherent with genetic testing at this point. Some of the challenges, and this is really more from a clinical standpoint, there's really many different laboratories that are offering germline genetic testing now. And there's many different, again, what we call panels available that have different numbers of genes and different genes ultimately that are offered there. Right now, there's technically an unclear consensus on necessarily the ideal number of genes to analyze and when to use panels. And there's variability in guidelines ultimately as well. When should we offer genetic testing? Should we offer it to this patient or that patient? What are the exact criteria that we should be using to determine that? That's sometimes a little bit fuzzy as well. And then also the management for patients that are found to have genetic testing or genetic mutations. So even when we do agree on who should have genetic testing, when we find patients that have mutations, sometimes for all of these genes, there's not necessarily clear criteria to say, okay, this is exactly what every single patient should be doing based upon this genetic mutation. And that also goes hand in hand with evolving data. We're hoping that as we gather more information, that we can have more clear consensus on that. And then, as I mentioned earlier, again, limited genetic counseling resources. It's really something where, unfortunately, at this point, not every patient has genetic counseling available to them. Again, hopefully mitigated a bit through some of the telehealth services and really the increased knowledge and availability of genetic counseling ultimately. Okay, so when is genetic testing appropriate? So, a common question that we'll get from patients is to say, is genetic testing right for me based upon my personal and family history? So just to touch upon family history a bit, I think it's important for patients to understand that genetic information about family members is important beyond just kind of your close family members. So a lot of people will say, okay, my first degree relatives, there's no one with cancer. But when you dig a little bit deeper and start asking about aunts, uncles, grandparents, even great aunts or distant cousins, sometimes it'll come up. And maybe it's not even information that they're readily know of originally. And oftentimes when they talk to their parents or talk to their extended relatives, sometimes more information can be learned there. And we also, again, understand that some families are rather private, especially the older generations. But sometimes I think the younger generations are now recognizing, and hopefully the older generations as well, that the discourse and open information here is only beneficial to the family overall. So, but we're really trying to discern or learn more information about extended relatives, I think is very important for patients to try to do if at all possible. Also, again, as I mentioned earlier, the type of cancer that the family member has had is very important for us to know. Again, I understand that it's not always possible, especially for some grandparents or great aunts, great uncles. That those could be diagnoses in the early 1900s. And it may just not be possible to figure out exactly what type of cancer it was. But when possible, knowing exactly what type of cancer it was, and even the pathology makes a big difference to us if at all possible. For example, as I'm sure many of you patients are aware, not all 2 kidney cancers are the same. There's many different subtypes of kidney cancer, and that same goes for a lot of other cancers as well. So as many details as possible is helpful from a genetics perspective in terms of our assessment. Again, the age that the family member was diagnosed, again, extremely important. Someone that was diagnosed at 30 versus 70 can have different ramifications from a genetic standpoint. Also knowing their current age or the age that they passed away is helpful for us as well. Also another thing would be whether the cancer was one-sided or two-sided. We use the terms unilateral or bilateral. Bilateral is typically a little bit more suspicious from a hereditary standpoint. And then also whether someone, sometimes patients will know that a family member potentially had cancer in multiple areas of their body. Knowing whether those were technically 2 or 3 primary cancers, multiple primary cancers, versus a cancer that has spread to another area of the body, which is what we call metastasis, is important as well. We typically will have more concern when a family member or patient has had multiple primary cancers versus a metastasis. A metastasis is not as relevant from a hereditary standpoint. It does not make it more suspicious. But if a patient has had multiple separate cancers, that does, in certain situations, make it more concerning to us. Touching upon characteristics of kidney cancer itself. So again, there are specific things that we look for. So typically an early age of onset, very roughly, and this is potentially subject to change, but as a loose guideline, anyone younger than 50 with a diagnosis will be potentially concerning to us. Anyone with bilateral tumors, so again, tumors in both kidneys is a little bit more concerning. Also what we call multifocal tumors. So this is more than one tumor in the same kidney. Sometimes that can be more concerning to us. As well as specific histology. So again, certain types of kidney cancers can lead us in different directions. There are specific genetic syndromes that are typically associated with various types or specific types of kidney cancer. So knowing exactly what type of kidney cancer someone had can help us figure out, okay, what else do we need to be looking for in the family that can make us more or less suspicious here. And then also, of course, family history of similar cancers. So if a patient themselves has had a kidney cancer and they have other family members with kidney cancers, or potentially things that are maybe related, such as neuroendocrine tumors, can be important for us to know as well. So we, again, are looking for patterns within a family that can help us point us in one direction or not. Simply, there are some families that will have a lot of cancers in them, but those cancers are not necessarily related to each other. So for example, there could be a couple lung cancers, maybe due to smoking, a couple skin cancers due to skin exposure, and then maybe a kidney cancer. So even though there are a lot of cancers in that hypothetical family, they don't necessarily all tie together, and that can be used for us to stratify how concerning or not concerning it may be. Some common questions that we'll get from patients as well. At this point, can genetic testing inform treatment? For kidney cancer, unfortunately, it is not really used to inform treatment at this point, but it's certainly one of our active areas of research, and hopefully we can change that in the future and use it more specifically for treatment of kidney cancer based upon what mutations are present. Another common question is, will my insurance cover this genetic testing? I would actually say this is probably the number one concern that we get from patients. I will say that insurance will often cover genetic testing if the patient meets that insurance company's specific criteria. Every insurance company has slightly different criteria ultimately, so there's not really a blanket answer that we can give there. I do also want to point out that genetic testing from an out-of-pocket standpoint, so if a patient does not have insurance or unfortunately does not have insurance coverage for genetic testing, it is becoming more attainable now. Most reputable laboratories will offer out-of-pocket genetic testing for $250. This used to be, on the order of several $1,000s. So we still understand, $250 is still obviously a decent amount of money out of pocket, but it is becoming more attainable, thankfully, for patients that don't have coverage otherwise. And then oftentimes patients will say, what will I do with this information from these genetic test results? How is this going to impact me? Why do I want to know this essentially? It can potentially determine if there's risks of other cancers or not, and can help us alter the screening, which again can sometimes be a benefit or limitation to a patient. Some patients will say, I have my hands full with this current diagnosis and I kind of want to just get through this. And if I were to learn, at this point in time that I have an increased risk of something else, maybe it's not the best time for that information. So again, sometimes patients will defer testing up front. And then also, again, it can be very informative for family members. Again, we do typically encourage what we call cascade testing. If someone is identified to be positive, we will do our best to help identify other family members that could benefit from genetic testing and identify genetic counseling services that are available to those family members should they wish to pursue it. Again, we do recognize at the end of the day that genetic testing is still a very personal decision for patients and ultimately something that we don't want to force upon them, but we do hope that family members are made aware of the option for it and the potential importance of it ultimately, and then they can make a decision on their own individually about whether they want to proceed with that. Some other patient considerations for genetic testing. One other common area that I get questions from patients, and sometimes even when I don't, it's something that we try to bring up with patients because we do think it's important. And this is about insurance discrimination based upon genetic test results. I do want to point out that there is a federal law that was passed in, I think, 2008. It is called, we abbreviate it GINA, G-I-N-A. This is called the Genetic Information Non-Discrimination Act. This is specifically for health insurance. So for most cases, this federal law will protect patients from health insurance discrimination. So for example, if a patient is found to have some sort of genetic mutation that is predisposing them to other cancers, health insurance in most situations cannot use that against them in terms of raising their rates or kicking them off the coverage. It is a federal law, so if a patient changes insurances or moves to a different state and changes jobs, for example, the new insurance as well cannot use that against them. I will say that one of the big areas that of concern potentially, which are valid, are life insurance, long-term care, and disability. So ultimately, the life insurance, long-term care, and disability, these are not covered under that federal law, quite unfortunately. And anecdotally, I am hearing from a lot of patients that life insurance companies, many of them now during the application process, are asking patients whether or not they've had genetic testing done and what those results are. And in theory, a life insurance company can use that as a determination about whether they'll cover a patient and what rates that they may have. Certainly the disclaimer here is that I'm not a lawyer, but usually we recommend that our patients potentially, if they're concerned about this, try to get life insurance or other long-term care and disability set up prior to doing genetic testing. So I do think that's important for patients to know about, especially patients that are unaffected. So for example, if someone is coming in based on family history, or, we do test someone that's had a kidney cancer and they're found to be positive, and their family members who haven't had cancer want to do testing, they may want to consider, again, looking into those things, those other types of insurance, and get them set up before going ahead. So I know I've been doing a lot of talking at you guys. I want to take a quick break for some questions, and we can go through and answer some of them as they come up.
I think we definitely have a couple questions that have come in. Obviously, there's a lot of different genetic tests that are out there. Some of them are specific to kidney cancer. Some may talk about being just cancer in general. Some are really large, looking at thousands and thousands of genes at one time. Because the specialists are sometimes hard to get in to see, are there any great ways for either clinicians or patients to try and sort out if they had the right test or they're ordering the right test for them?
That's a great question. It's a little bit tricky to navigate because every laboratory has different trade names for their tests. So I would say it's important when talking with your physician or a genetic counselor to see what genes are actually on the test. Because, some of the names are not very apparent. You have names like Cancer Next, MyRisk, Multi-Cancer Panel, things like that are, rather generic, and it's hard to necessarily know exactly what's on the test. I have a slide in a little bit that lists kind of the current major genes that are associated with kidney cancer. And I would say it would be important, if the patient does want a panel related to kidney cancer, to make sure that those specific genes are involved there. Very historically, just to take a very rudimentary approach to it, the most common genes from a cancer perspective, obviously has nothing to do with kidney cancer, are BRCA1 and BRCA2. A lot of patients will know them as the BRCA genes. But in a very egregious example, sometimes if a physician that doesn't really know much about genetic testing and a laboratory kind of advertises genetic testing, that's probably the most common test that would be ordered. But for a kidney cancer patient, completely inappropriate, because there's no real overlap between kidney cancer and BRCA mutations. So knowing what genes are on the test, I would say, is extremely important. And being an advocate of your own, patients being their own best advocates, I really advise that whenever possible. So knowing exactly what genes are on the test would be a good start there.
I think it's also important too to note, there's definitely different companies popping up all over the place that are starting with testing. Just because they're a new company doesn't mean their test is any worse than a company that's been around for a long time. But I think making sure, if it's a laboratory that's associated with a university or an academic where you're going to get a good review of results versus just get a result and then not know what to do with it, having genetic counselors that work at the lab that you're ordering the test from so they can help the doctor interpret the results and make sure the test is appropriate can also be important. You talked also about genetic counselors being, hard to find or low. What's one way, a resource where they could find a genetic counselor or genetic specialist to do the review of all those factors you mentioned?
There's actually a great website through what we call the National Society of Genetic Counselors. It has a very simple name. It's called findageneticcounselor.com. I actually have it on one of my ending slides, so if you need to grab it there. But again, it's findageneticcounselor.com, and you can input, I think they go by location, and then you can ask for specialty, and you should be able to find either someone local to you or someone that's offering telehealth services, whether it's through insurance or sometimes it may be cash pay. But you can find someone that can potentially talk with you. And to Sally, your point about the prior question, I did want to bring it up as well. A lot of patients these days come in asking about kind of what we call direct consumer tests, which are most classically things like 23andMe or Ancestry, which I believe has discontinued their medical aspect, but in the past had it. A lot of patients will ask whether that is, appropriate genetic testing, or they'll think that because they've had that, they don't need kind of more clinical-based genetic testing. I do want to really stress that companies like those, in particular 23andMe and Ancestry, are extremely limited from a cancer genetics perspective. It is really not, quite frankly, an appropriate test to determine whether someone has, for example, a hereditary form of kidney cancer. While they do some cancer genetic testing, it is very limited in scope. Most of them are looking at BRCA mutations, and specifically ones that are common in certain populations, such as the Ashkenazi Jewish population. So it's really not an equivalent for the clinical genetic testing that we typically order for patients. They are, potentially useful if the patient wants to know what their ancestry is and what their background is. By all means, can consider it there. But from a clinical perspective, I'd be very cautious of using those as a surrogate for clinical-based genetic tests.
Absolutely. If someone has had genetic testing in the past, whether, for whatever different reason, when should they be thinking about getting an update, or do they need to be tested again? How do they determine if they've already had testing, what might be new for them?
Kind of a general rule of thumb is for most of my patients, even if they're negative, I encourage them to reach out to me in about 3 to 5 years to see if any new testing is available or if their family history changes. Obviously, we hope it does not, but if anyone else in the family does develop a different type of cancer, that's important for us to know about. That can potentially change our thoughts on what genetic testing is necessary for the patient and or their screening guidelines. So again, roughly 3 to 5 years, assuming there's no change in their family history. I often encourage my patients just to email me or call me, and we can just have a quick chat and see and reevaluate whether anything is necessary for them. I would also say that there is an option that we call DNA banking that I think is potentially helpful for a lot of families that is not commonly known. So this is potentially useful for really, we're talking long-term use. So DNA banking is basically a service that private laboratories will offer, typically with an associated out-of-pocket charge for storage, but they'll store someone's DNA for up to 50 years, 50. This can be really helpful for future generations. So say you have an older patient that maybe in their 70s or 80s, for example, and they're the ones that have the most suspicious cancer. Potentially banking their DNA for future use for their children and their grandchildren can be very helpful. There's been a lot of scenarios where I've seen younger patients where they say, okay, my grandfather had this rare type of cancer, but unfortunately he passed away and we can't test him. But we would get a lot more answers if we somehow had the ability to test that affected family member. So I would say DNA banking should be something that most families can consider. I don't remember the exact charge off the top of my head, but one of the main labs charges about 200 or a little bit less for the storage fee for, again, about 50 years. So I personally think it's a good investment for families overall to consider, again, and that's something that is not typically offered to patients because I just don't think it's well known enough. But I think patients should potentially consider that, especially if there's older individuals in the family that have the most suspicious cancers.
I think that the next two questions are sort of related. You had talked earlier about there's two different types of genetic testing where they may test your blood looking for something that was either inherited or something that could be predisposing you to kidney cancer versus testing the tumor itself. Is there a reason to have them both done at the same time? Is there a sequence to do those? When do you decide which testing might be more appropriate?
That's a good question. I don't think there's necessarily a direct answer right now. Every center does it a little bit differently, ultimately. Some centers will do tumor testing on, for example, all of their advanced cancer patients, and others, they kind of pick and choose based on what the oncologist thinks is informative for them. Some places and some laboratories are starting to offer paired testing where they do both germline and somatic testing at the same time. I will say the most common way that it's done right now for cancer patients is a lot of oncologists are ordering tumor testing, and then based upon those results, and I have a slide on it, we'll go more in detail, but there are certain things that we can look for in the tumor test that can inform us whether genetic or germline testing is necessary or not. It's also important to recognize that germline testing or inherited testing is a valid thing to do despite what the tumor test results may show, again, especially if there's a strong family history. So I would say while they are both, connected to an extent, they do have very specific reasons to do them, and they don't necessarily have to be tied in to each other. Someone could certainly have only tumor testing or only inherited testing, or sometimes both would be indicated for them.
Yeah, and I think that's one of the things that gets confusing sometimes with genetics is people think, we talk about genetics and cancer, and if I have a family member with a cancer, I'm going to be really, really high risk to get one. And that's not always the case. It does depend on who the family member is, what type of cancer that they had. So having that family history does not necessarily mean you're going to get cancer. Sometimes even having one of the genes that are altered that increases the risk. For instance, when we think about breast cancer, which is one of the most common ones talked about as being inherited, even having a change or a mutation in that BRCA gene, still only 80% chance. So it does increase it from 12, but it's still only 80. There's still people that don't get cancer even with those genes. And when we think about people who don't have any history, doesn't mean there's not a genetic cause behind the cancer. And just because there's a mutation that you find in the tumor, doesn't mean all those people are going to act the same way. You could have a mutation in the tumor that you didn't inherit, that was happening brand new, and you could be sitting next to the waiting room with somebody else who has that same exact mutation in their tumor. but we have thousands of genes that are all acting together on things. And that could really determine how that tumor is going to act, what treatment may be helpful. And so when you're testing the tumor itself, those mutations give us a clue as sometimes maybe the pathway that's breaking down, the bypass system or the check system that's not working right. And it's trying to give us an idea of how do we treat this better. There are no exact treatments for a specific mutation, although people with von Hippel-Lindau recently had their medication approved, the Welireg, that was approved in patients who have von Hippel-Lindau, which is an inherited form that can involve kidney cancer. But there's not a specific mutation within VHL that actually tells us about the medication. It's the condition itself. So when you're looking at the tumor, you're just trying to get some ideas. And kidney cancer really needs some advancements before we're going to be able to link a lot of those mutations to personalized treatment. But I'm definitely excited. I've been doing this for 20 some years now. It's hard to say how long for the whole world watching, to see just how things have changed. And what I think isn't possible changes 6 months from then, and I have to change my information. So I think you do have a couple more slides, so I do want to switch over to that, and we'll sort of continue to monitor questions coming in. I do want to remind everybody that these talks are recorded, and we will, definitely be trying to put out summaries and resources to you after the talks as well, for those of you that have been asking that. But John, why don't you continue with some more information?
Of course. So the next part I want to highlight is kind of the current state of genetics in kidney cancer. So this actually goes back to one of the questions that was there in terms of kind of what genes that you want to know are being tested for. So I have a list here of kind of the major genes that are currently associated with hereditary kidney cancer. They do include VHL, TSC1, TSC2, the SDH genes, and a few others as well. These are, again, and FH, of course, is one of the big ones as well. But these are the major ones that we know of right now. I did want to highlight a study out of Memorial Sloan Kettering back from 2018. They specifically looked at patients with advanced renal cell carcinomas. They looked at 254 patients, and they found that 41 of these patients, which equated to about 16%, carried germline mutations. Of note, about 5.5% of these were in currently known renal cell carcinoma associated genes, and then the other 10.5% were in other genes that aren't as commonly associated there. But this is the type of research that is very interesting to show us a little bit that potentially our historic criteria for doing genetic testing may be missing some patients. And it's similar to a lot of other cancer sites that we're looking at as well from genetics. We're now recognizing that a lot of our old criteria might have potentially been a little bit too restrictive and too inclusive, and we might have been missing patients with germline mutations because we had such restrictive criteria. A lot of the reason that we had restrictive criteria was the cost of genetic testing, which again used to be very, very expensive. A lot of those costs are dropping now, and we can do these multi-gene panels really for the same price of doing one gene at a time before. So it's making a lot more sense to potentially consider sometimes doing some of these bigger tests. Again, not necessarily the right answer for everyone, but it is changing the field a bit in terms of making it more accessible ultimately. Next one is tumor testing. I wanted to touch upon tumor testing to give you guys a brief overview similar to what I did with the inherited testing. So tumor testing is certainly becoming much more prevalent, again, particularly in the setting of advanced cancers. As I mentioned earlier, every center does have different protocols. So there's not one standard to say, if you're treated at hospital X versus hospital Y, that you would necessarily be offered the same tumor testing, unfortunately. Some centers do test all patients with certain advanced cancers and others do not, and kind of pick and choose whether it's based on the cancer site or the stage. But really, it's something potentially worth asking your oncologist to see whether they think that's something beneficial to you. The whole point and benefit of doing tumor testing or somatic testing is the possibility of identifying actionable alterations that might guide systemic therapy decisions. As we discussed earlier, unfortunately, with kidney cancer, there's not that many actionable alterations right now. But again, this is something that, again, is rapidly changing. So in the future, we do hope that tumor testing will be a lot more beneficial specifically for kidney cancer patients. Again, the limitations go hand in hand there. Again, not all cancer types, which include renal cell carcinoma, have clear therapeutic impact at this point in time. But it's really something that is revolutionizing a lot of other cancer sites, in particular breast cancer, colon cancer, pancreatic cancer, and others, ovarian also. And we hope that trickles down to kidney cancer as well in the near future. Those cancer types, similar to Sally, I've been in this field for quite a while. It's really quite amazing to me how things have progressed even over the past couple of years, and we have a lot of hope and excitement that it'll continue to improve as well. Again, hopefully for kidney cancer also. I did want to point out that, again, the relationship between tumor testing and germline testing, while they are inherently similar, there are distinct differences. And again, they don't necessarily have the same results even. So if someone has a negative tumor test, it doesn't necessarily mean that they should not have germline testing. Not every germline mutation will show up in a tumor, and there are various reasons for that. Sometimes there's what we call tumor heterogeneity. Basically, different areas of the tumor may have kind of different prevalences of mutation, and sometimes it'll be dependent on what part of the tumor that they test, which is quite frankly a little bit random. So it can sometimes miss a germline mutation there, or something that we call allele frequency. It might be in particular a low frequency at that part of the tumor that they tested ultimately. So even if someone has a negative tumor test, they might still have a germline mutation and might still want to consider that, in particular, again, if they have strong family history and such. And then also for someone that does have positive findings on a tumor test, there's various characteristics that genetics professionals will look at in the tumor testing report to determine if germline testing is indicated based off of that. There are some genes that are very commonly mutated in tumors that are not really thought to be commonly hereditary, such as TP53 and APC. While those can be hereditary, those are very rare conditions and are commonly mutated in tumors. So there are certain things that we look at within the tumor test report to see whether germline testing is warranted to confirm whether a mutation is germline as well. If you're curious about this, I would certainly advise that you talk with your oncologist or whoever ordered the tumor test, to see, or potentially talk with a genetic counselor and see what their thoughts on it are as well. And then, as I mentioned during one of the other questions, paired testing of doing both somatic and germline testing is becoming a bit more prevalent, and I would not be surprised to see that become more standard of care in the future. So a lot of places are potentially doing both of them at the same time just to gather as much information as possible. But again, not a clear consensus right now to do that at this point in time. I did want to touch upon a clinical consensus statement. So there was a recent publication earlier from this year, and this was really the first ever consensus panel for RCC genetic risk assessment. And overall, rather surprisingly, this has never happened before. So as I mentioned earlier, some of the limitations or challenges of genetic testing have been that there's not really clear consensus on who to test, what genes to test for, and what to do with that information. So this was a North American multidisciplinary panel, and really the goals of this panel were to address this lack of guidelines. Again, how and when genetic risk assessments should be performed, in particular in relation to hereditary renal cell carcinoma. They do acknowledge that the current guidelines, whether they're through an organization that we call the National Comprehensive Cancer Network or NCCN or American Urologic Association, they may miss a significant portion of hereditary renal cell carcinomas due to what we call incomplete penetrance, basically meaning that not everyone with a genetic mutation will actually develop a cancer. And then also diverse presentations of hereditary syndromes. Not every family is going to have the same exact cancers or other associated features of the condition. So this group, they looked at 53 curated consensus questions, and they found that for about 30 of those statements, they received uniform consensus among their members. Uniform consensus in this study or panel was defined as 85% of the participants agreeing. So overall, just some brief things where they did agree. I have listed here, they found that patients with renal tumors and a first degree relative or 2 second degree relatives with renal cell carcinoma, everyone agreed that genetic testing should be offered for them. So again, those are some things that patients should look out for in their family histories that right now, I think most people would agree that genetic germline testing would be appropriate for. Again, specific renal cell carcinoma histology, again, certain subtypes of kidney cancer will be more obvious for us to offer genetic testing for. And then again, bilateral or multifocal renal tumors, most people do agree that we should offer testing there. Areas of disagreement are age alone cutoff. So again, whether it's 50 or 45 or a different age, again, there's a little bit of ambiguity right there. Maybe we're missing someone who's 53 that, does have a hereditary condition. So right now, there's not really a clear consensus on exactly what age we should be doing. Also, single gene testing versus multi-gene panels. Some people still think that if a patient, for example, has all VHL associated cancers within the family and characteristics, maybe we should just offer VHL testing rather than even a 15 or 14 gene RCC panel, versus if someone has multiple types of renal cell carcinomas in the family, maybe we should offer a multi-gene panel. Again, there's no clear guidelines there. And also the timing of when genetic testing should occur during the workup and treatment. Some people think it should occur earlier. Some don't think this is important because, again, of not informing some treatment decisions. So there's no clear consensus there. And then also how to interpret those uncertain results. Again, there's a little bit of ambiguity of how we should be handling those within the RCC world right now. Overall, though, I think it was a great idea to have this clinical consensus group put together. I think it's very exciting for our field to see this process started within kidney cancer, and it'll certainly be interesting to see the future impacts of this on, again, establishing clinical recommendations for genetic testing. Hopefully we can have something more uniform, which I also think will trickle down to improved insurance coverage. A lot of these insurance companies do look towards these national guidelines to inform what they will cover or not cover. And then hopefully this, it's all a trickle-down effect. If the insurance coverage gets better, it'll increase the accessibility of genetic testing for patients. And then in the future, hopefully we'll be able to refine some of the consensus statements that did not currently meet uniform consensus, and we can get a better handle on what to do with those. Touching upon some future directions in the field overall. So I think, again, one of our goals is to improve the treatment selection based on genetic test results. As we've mentioned, again, right now, unfortunately, with renal cell carcinoma, really the germline testing and tumor testing is not informing treatment decisions very directly. But as I mentioned, within some of the other cancer areas, ovarian, breast, pancreatic, et cetera, hopefully it'll follow suit there, and we'll have much more tailored recommendations offered to patients, really as a goal of precision medicine overall. And then hopefully we will continue to identify other genes that are associated with hereditary kidney cancer beyond the list that I provided earlier. And then again, refinement of a full clinical spectrum of currently known syndromes. We're still learning more and more about these syndromes. Some of them are fairly rare, so we haven't been able to study them fully. And as we identify more patients with these syndromes, we're learning that there's either different levels of risk that we previously thought, or even different types of cancers that might be involved in these conditions than what was previously believed. And then also wanted to highlight some resources that are available to patients. Obviously, Kidney Cancer Association doing great work. And then specifically, if a patient has VHL Alliance is a very good resource for patients. Theo-Para Alliance, those are the SDHA, SDHB, SDHC, and SDHD genes primarily, of which RCC does have involvement. There's a group called the Theo-Para Alliance, which is similar to the VHL Alliance, is doing very good patient awareness and work there. And then the other resource that I mentioned earlier, which is the findageneticcounselor.com resource, which is an easy way for patients to find a genetic counselor that's available to them, whether it's in person locally or potentially through telehealth as well. And then just to wrap up here, some key takeaways. Again, genetic testing, potentially may be beneficial if you've had kidney cancer. And again, recent data is suggesting that our previous guidelines have possibly been a little bit too restrictive. And hopefully we'll be able to work on changing the accessibility for genetic testing for patients. And then overall, genetics knowledge is really advancing rapidly. Again, I truly am excited for the futures of genetics in terms of cancer care. And hopefully soon, renal cell carcinoma will be part of that, similar to other cancer sites as well. And also just a quick plug again to check back in with your genetics provider on a routine basis, again, maybe every couple of years, to see if there's anything new that's relevant to you in particular. Thank you for everyone's time. I have maybe 2 more minutes to answer a couple more questions.
Great, John. I think one of the questions that popped up as we were talking about VHL and whether or not the mutations are used for treatment that we could probably clear up is the question was, so a mutation in VHL for a patient who has kidney cancer, does it really mean anything for cancer treatment if the patient doesn't have von Hippel-Lindau disease? And I think one of the things we have to know or sort of mention about genes is just because you have a mutation in a gene doesn't always cause the disease. There are, you mentioned mutations that sometimes we don't know what they do, or they don't really change things enough. It's almost like a misspelling in a word when sometimes you misspell it, but you still know what the word is, versus there's other misspellings that really change the meaning of the word or you can't recognize it. And von Hippel-Lindau is usually diagnosed by the cancers that are there, not necessarily, you don't have to have the mutation because not everybody has a mutation that they know about. Genetic testing isn't 100%. So if you do have kidney cancer and your doctor has said, you have kidney cancer, but we're not necessarily seeing von Hippel-Lindau disease, there's a lot of things that can go into that diagnosis. But what we were talking about with the mutation and treatment is that just because we have a mutation, we don't have a drug that says this drug treats this mutation in kidney cancer. But the mutations can still help the doctors sometimes decide what management may be appropriate, may help make them decisions on things. So those mutations can still be important, and it's constantly evolving, as John had said. And so you definitely, want to seek out information, and those specialists can be important because genetics is massive. There are thousands and thousands of genes. No one person understands them all. And so making sure you seek out and look for those answers. But John, is there any last sort of minute thing you want to mention? Otherwise, I think you set us some great resources that we can share.
I think that's all I have. Again, thank you all for allowing me to participate today.